Next.
Okay, the following speaker will be Dr. Nohad Ibrahim. Dr. Nohad is a professor of Department of Breast Medical Oncology from the M.D. Anderson Cancer Center, Houston, Texas. Dr. Nohad will talk about novel systemic treatment in patients with breast cancer and brain metastasis.
Good afternoon, Mr. Chairman. Thank you for the introduction. And again, I want to thank the organizers and the scientific committee, particularly Dr. Ghazali, for inviting me and giving me the opportunity to discuss novel systemic therapy of metastatic breast cancer to the brain. When I was asked to give this topic, I said, oh my God, what I'm going to talk about. But thinking a little bit deeper than the surface of the skin, I found out that I really can say something that might be useful, and at the same time not to upset any of my colleagues in the audience. In fact, I benefit very much from the presentation of Dr. Hamdi Abdelazim, because he covered a lot of material that I felt I may not have to go over it again, but just kept very skeleton information so that it connects to my basic presentation. In other words, metastatic breast cancer to the brain is a very common, accounts to about 15% of the patients who develop it. However, at autopsy series, it may go up to 30%, just reflecting the significance of the problem. And anticipated that probably if patients may have the chance to live longer because of better therapy, probably we may continue to see more and more metastatic disease to the brain. Unpublished data from our institution says that the development of brain mets can have bimodal pattern. One at about less than 1 year, and the other one, another peak, is about 5 years from the time of diagnosis. Not a brainer. The mechanism of spread can be arterial, venous, or a direct extension from the leptomeninges or from the bone, and remain to be determined the exact causes and the mechanisms which may heavily depend on the blood-brain barrier, or better called, or probably blood-tumor barrier, as well as the brain microenvironment, and also probable, what we think very heavily, that mesenchymal transformation may play a role in that transformation. Usually it presents as a solitary or single lesion in about 50% of the cases, and less than 5 lesions in about 30%, and multiple lesions in the brain in about 20%. This leads us to how it is addressed at the present time, either by surgical resection, whole brain radiation, stereotactic radiation, or intracavitary or interstitial brain radiation, as well as probable use of radiosensitizers. So far we did not talk very much about systemic therapy. Therefore, when now we see a patient with metastatic disease, and I have to agree with Dr. Hamdi that this slide is really tough. That first of all, we have to look at the status of the systemic disease. Performance status of the patient may influence the ways that this metastatic disease may be addressed. Associated morbidities, age, time to presentation to the brain. Some patients will present very early in the course of the disease or much later. And most importantly, sensitivity to radiation. As you know that different diseases may respond differently to radiation therapy. For example, some malignancies can be considered very sensitive to radiation therapy, such as lymphoma, germinal cell tumors. Breast cancer, unfortunately, falls in the intermediate group, but there are also groups that are heavily resistant to radiation, such as renal cell sarcoma, melanoma, and sarcoma. not projecting very well, but this is meant to say that there are several paradigms to evaluate the prognostic scores of brain metastasis. And let me skip on this and keep going without it. Currently speaking, the brain metastasis is treated classically either with whole brain radiation, particularly if there are multiple lesions in the brain, or if there are one or few lesions that are resectable, surgery followed by radiation therapy. And it's been shown in multiple randomized trials that the combination of surgery followed by whole brain radiation, when applicable, may have improved the median time to recurrence in a significant way, as shown in at least 2 of the randomized trials. With the introduction of stereotactic surgery, there was a significant shift from open surgery to SRS when always when applicable, and showing that in these randomized trials that SRS followed by whole brain radiation is better than whole brain radiation and improves the median time to recurrence significantly. However, there still keep the patient under a significant risk of recurrence within 1 to 2 years. So this brings us to, is there a medical management to metastatic disease to the brain? And to deal with this, initially we have to deal with the blood-brain barrier and the microenvironment of the brain to better understand how to plan management of metastatic disease to the brain. Of course, the target is that we deal with it exactly as we do with the systemic disease. Hopefully, we can engineer the right drugs to which breast cancer is sensitive, and also to get it to reach the lesion in the brain. What we are dealing here with is the microvasculature of the brain parenchyma, as outlined in a very nice cartoon by Dr. Hamdi, that it is a very tight endothelial layer over there, and lend itself very little to any leakage of drugs. And really it meant to be so because the blood-brain barrier will protect us from a lot of you may call it poisons or toxins that we may take, may not affect significantly our systemic organs, but if reached to the brain, may be very, very bad. So it is the act of Mother Nature, but at the same time, it's fighting us now to allow us to treat metastatic disease. The blood-brain barrier can be leaky in the presence of metastatic disease, and as the larger the tumor is, the more leaky it is, and it exceeds more than it gets open more than physiological limit in lesions greater than 0.25 millimeters. Also, what we don't know is about the nature of the vasculature in the tumor. Is it the same all over? Or is it different centrally versus peripherally in the lesion? And this is what we don't understand. Also, we don't really understand the mechanism of permeability, meaning active permeability or passive permeability of the blood-brain barrier. And these are all important issues while you are attempting to engineer a drug to cross the blood-brain barrier, and for that matter, again, the blood-tumor barrier, so that you'll be able to treat the tissue. So the blood-brain barrier is just not a layer that we just poke into it and get things in. It is a very complex structure, and these tight junctures of this structure may allow water-soluble molecules to go in. We know that, but can we get water-soluble molecules to treat brain metastasis? And also, it may allow lipid-soluble molecules, and therefore we have to keep an eye on the mechanism so that we can deal with it. Basement membrane, how we can also manipulate the basement membrane to allow drugs to go in. Endothelium, And there are, we know that there are in the endothelium receptors that mediate transcytosis. Think of here insulin and transferrin. And absorptive transcytosis, we know that albumin go in. But when we go, for example, albumin-based Taxol like Abraxane, we don't see a significant improvement in that aspect. The microenvironment of the brain also play a significant role, the most important of which is astrocytes, and not to underestimate pericytes and the microglia. The microglia also have the receptors for IL-10 and IL-2, the TNF, and more importantly, Wnt gene. And I say more importantly because we have drugs that affect the Wnt gene, but remain to prove to be effective in systemic disease before we proceed to employ it in the management of metastatic breast cancer. As well as we need to pay attention to the physiology of the fibroblasts in the microenvironment of the brain. Drug transporters, influx, including low molecular weight receptor protein 1 that helps in the transfer or pumping of the drug inside the brain from the vascular bed to the brain parenchyma. However, you have also to work against the efflux mechanisms such as MRP or PGP, etc. And there are also markers of integrity of the blood-brain barrier, which may be used to guide us in the integrity of the blood-brain barrier. So indeed, the objective can be achievable, but the job is very complex and very hard. For example, talking about the astrocytes main role in the brain is to protect the neurons from neurotoxicity and injury in induced apoptosis. And there are elegant experiments to prove this point, which I skipped here for interest of time. Treatment modalities, many drugs has been tried, and Dr. Hamdi elaborated on a couple of things this morning, but also I want to add to this list temozolomide. But again, we know temozolomide is not very effective in breast cancer systemically, so how would you expect it to be effective in the brain? We know it crosses the blood-brain barrier, but I don't know how would expect otherwise. Taxanes, topotecan, platinum salts, among others. What is surprising here is that there is multiple small studies looking at chemotherapy and effects on the brain. You know, when you look at the responses, they are pretty impressive, and you wonder, why do we have brain metastasis in the first place if we have such a good response, knowing that most of the patients received at least some of these agents, and if there is micrometastasis in the brain, it should have taken care of it in the first place, but we see that this is not the case. I believe reporting of responses in many of these studies may be due to either being older studies, and assessment of brain metastasis might have been not very accurate, or for a lack of statistical power, we may not necessarily consider them as important. You heard a long discussion this morning about lapatinib, and there were issues whether lapatinib crossed the blood-brain barrier or not, and indeed it does. That I did not add it, that was there from the beginning, so I'm not playing sides here. And it shows in this carbon-14 labeled lapatinib, also looking at the fluorescent studies at the same time, showing that the green fluorescence and the red fluorescence are called Texas fluorescence. I don't know why they call it Texas fluorescence. And radio-labeled study indicated indeed that lapatinib penetrate the blood-brain barrier or the blood tumor barrier in significant concentrations. And there is at least several studies looking at the effect of lapetinib in management of brain metastasis and the combination with capecitabine, and it gave a various ranges of responses from a low single digit to up to 40%, and this led to more studies about this combination in the brain, and I want to go over some of them. The most important really is the one that was reported recently in Lancet Oncology, looking at lapetinib plus capecitabine in patients who have untreated brain metastasis. It's a single one group phase 2 study. And really this is the kind of study that we need to do to learn about the tumor without having other effects of the tumor barriers such as surgery or radiation therapy, because we don't know how much scarring from surgery or effect of radiation therapy may compound the transport of the drugs further into the tumor. Having said this, it may also facilitate. We have no idea about how it's going to affect it. All these studies, in all these patients were selected where the score, the prognostic score of the brain tumor, according to one of the scales that was not projecting nicely, score 3 and 4, where patients are expected to live 4 to 5 months in group 3 and up to 11 months on the reverse. Group 4, 4 to 5 months, and group 3 up to 11 months. And on this study, this same group, their survival improved to 17 months. I think this by itself is a great news that there are something there, but that lapetinib and capecitabine may work in metastatic brain tumors. And I really want to congratulate Dr. Hamdi Abdelazim for taking this further and using a vasodilator, hoping he can help better penetration of the drug into the brain. When you look at the different subcategories, although this is a very small study, you may see numbers that may not help you very much. For example, while the overall response rate was 77% in patients with performance status 0, it dropped down to 58% in performance status 1 to 2. Also, the tumor burden had some effect on the results. 1 to 2 lesions response rate 58, more than 2 lesions 73%. Prior trastuzumab did not affect the results. Looking deeper into this, it comes to your mind several questions. There were differences in responses between symptomatic and asymptomatic CNS, and you wonder, is there any selection bias? And for that matter, if so, why should it matter? The second question would be the response rate extracranially was less than in the CNS. And really, this is something that I cannot understand. And even when we discussed the same study after it was presented in ESMO of this year in our department, also we were not able, in our group also we were wondering, why is this? At the same time, if you compare two responses to the frontline registration study of capecitabine and lapetinib, also the response rates here in the CNS was also higher than expected. And I think this remained to be addressed, and I hope the author will look at his data and address these issues. So having said that, I would say that this combination is only good for hypothesis generation, not for standard of care. In other words, not for primary therapy of metastatic breast cancer. I would still use it if for lack of options, for example, any research protocol that address systemic therapy of brain after progression from radiation, or if you want to evaluate something up front, but this not to be used, in my opinion, as a front line for metastatic disease because of, first of all, a very small study needs confirmation with the larger studies, and a lot of questions need to be addressed. Cerebral trial, which also was done in France, trying to prevent metastatic breast cancer by using chemotherapy. And again, this study was not a great success, I believe, because they were not able to identify a lot of patients that they can detect and show that it can prevent the brain metastasis. The numbers were very small. Let me skip the background. And for that matter, they were not able to look at progression-free survival, overall survival, or a response rate. The plan of the study was a combination of lapatinib versus capecitabine compared to trastuzumab versus capecitabine. And the basic question here is, would trastuzumab plus capecitabine be better or equivalent to lapatinib and capecitabine in preventing breast cancer? And again, you see here that CNS as first site of relapse in the brain were very few numbers, 8 in the lapatinib and capecitabine, 12 in the trastuzumab and capecitabine, not statistically significant, and therefore they were not able to determine any important results from the study. But I believe, and the primary investigator is aware of that when they were screening for patients to put them on the study, they found out that they have several patients of undisclosed number that they have very small lesions in the brain that were asymptomatic. They are in the sub-centimeter lesions, and they are following up on them, and probably may be able to determine the natural history of these patients. Let me move on. What are ongoing lapatinib studies? The list is very long and looking at the various combinations as a single agent or with chemotherapeutic agents, including taxanes and capecitabine as well. And it will be very interesting to watch these results and to see if they can convince us to think of this doublet in one way or the other. Again, more studies that are looking at patients with HER2 positive tumor, and showing that most of these studies are addressing the issue of brain metastasis to see if it can manage it. So, is it a closed door? Are we hitting the wall with this subject, or what should we do? If we go back to this pathophysiology slide that I put there, I went down with every single item and to see what are we doing with every item. Are we doing something or what are we moving? The sphingopalantine ganglion seems to be an important ganglion when it comes to the blood-brain barrier. And it induces, when it is stimulated electrically, it induces cerebral vasodilation and moderately dilating the blood vessels and increase the blood flow in the brain. And also in animal studies, it shows that intense stimulation, chronic or acute, can induce a temporary controlled increase in permeability of the vessel walls. And indeed, there are small devices that can be used in human beings. And at our institution, indeed, we are working with this company to start a study to see if it indeed increased the permeability of the blood-brain barrier when giving chemotherapy. And we went a long way with that study, and guess what? We got stuck with budgeting, and now we are waiting on money to be able to do the study. Lipophilic pathway. We know that many drugs, particularly chemotherapeutic agents, are lipid-soluble molecules. Most prominently that we know of is the PARP or the and the mTOR inhibitors. And indeed, there are studies currently using PARP inhibitors, particularly in triple negative, trying to see if it can prevent metastatic breast cancer to the brain. We had a study of this at our institution that was closed several months ago, and we are waiting for the analysis of the data. BKM120 is a TKI inhibitor, small molecule, and we are also planning to study it in the management of metastatic breast cancer to the brain. Currently is on stage 1 with the extended phase, looking at its efficacy in the against systemic metastatic breast cancer. But there were incidental finding of 3 stable. Am I late?
Aye.
3 stable metastatic disease in the brain. Again, a third molecule, which is a group of 3 molecules of paclitaxel combined by a proprietary amino acid, 19 amino acid peptide, which combine to LRP1 receptor on the meninges, and it always only help to transport the paclitaxel inside the brain. Hopefully will achieve a higher concentration of paclitaxel in the brain, and being effective drug, we hope that it may do some activity there. We have a protocol. We started it. We have a few cases. Then we amended the study again, and it is active one more time. To affect the efflux, we have 2 molecules, TPI-287, which is a tubulin inhibitor, far more effective than taxane and epithalones in the laboratory, and also is not affected by MDR, and therefore is more effective than taxanes in MDR positive breast cancer cells, as well as various other tumor cells that are MDR positive. And also we have a study currently accruing for 2 groups of patients, those who are newly diagnosed, and the other group are those who failed radiation and or surgery. RTA-744 is a derivative of doxorubicin. This drug was developed at MD Anderson, but another company came and bought it out, and hopefully that they will develop it in brain metastasis, but again they got stuck with financial issues. Last but not least is development of nomograms to predict chances of the development of metastasis to the brain, and this is not for clinical use. They're not going to help us in the clinic, but probably to enrich the patient population for research purposes. For example, depending upon where you choose to prevent to detect more than 15% brain metastasis, then the planned study may take 260 patients to get all these patients on board. If you choose, for example, cut-off line of 30%, the number drops down to 50%. 130 patients would be good. And we think that the use of such nomograms may help predict who is at higher risk and maybe need to go on the study, so that the data does not get diluted. Again, this is as much of the complexity of the study. Brain metastasized primary breast cancer metastasized to the brain, and remain to understand whether this cell, when it goes to the brain, does it maintain its genomic makeup, or is it affected by the microenvironment of the brain when it gets there and acquire different genomic characteristics, or could this cancer cell that made to the brain came from a metastatic site where may or may not be affected by the microenvironment of the metastatic site, and again, when it goes to the brain, we may run again another round of genomic modification affected by the microenvironment of the brain. So